And I want to introduce Stephanie Brown. Steph is an advanced clinical practitioner, plastic surgery, orthoplastic trauma and complex wound management, the University Hospitals of North Midlands NHS Trust, which is the Royal Stoke Hospital. Steph is also a co-opted trustee of the Society. And Steph's going to be talking about some work that she's done around using compression as part of lower limb trauma management in plastic surgery settings. So over to you. Thanks, Steph.
My name's Steph. I'm an advanced nurse practitioner for orthoplastic trauma and complex wound management. So I've been an ACP for, since 2015, working across a range of clinical areas, including spinal surgery, health and justice, and as I say, currently within complex wound management for plastic surgery and orthopedic trauma. I was co-opted as a trustee for Society of Tissue Viability in 2025, so earlier this year, and I was able to present at that conference earlier this year. And just to say that I've been a member of the Society for a couple of years now, and I was fortunate enough to get the bursary to go to the European Wound Management Association. So it very much is worth joining. So I work at University Hospitals of North Midlands. We're a major trauma centre since 2012. We serve a population of nearly 3 million people, and that spans from Anglesey to the Peak District, so a real wide and broad area geographically to manage these trauma patients. So we'll just crack straight into lower limb then. So the lower limb is a complex network of systems and structures. We've got the arteries responsible for the supply of oxygenated blood and veins responsible for the return of deoxygenated blood. And these are often located within the same vascular sheath, which means that the arterial pulsations do aid venous return. We've got the nervous system, which sits in the lumbar plexus, a network of nerve fibres, supplies skin and muscles. We've got the lymphatic system, which serves to drain tissue fluid, plasma proteins and other cellular debris back into the bloodstream, and also involved in immune defence. And we've got the musculoskeletal system, which provides the framework for the body, aids movement, protection, blood cell production, mineral storage, and we've also got the skin. And there's a functional interdependence within the lower limb, and therefore any disease, injury or incompetence in one or more of these systems can have a profound effect on skin health and wound healing, and especially within the venous and the lymphatic systems. So when the function of one or more of these systems are affected, there are a myriad of factors that may affect wound healing of the lower limb. And when that wound doesn't heal in a normal trajectory, we do classify this then as a leg ulcer. And you can see from some of these pictures and those that I'm going to be discussing within the presentation is that the severity of some of these injuries and the wounds on the leg is that healing trajectory of 2 weeks may not be realistic, but certainly lots of other factors to consider. So the specialist nature of this education day suggests that most of you will already be familiar with and have an understanding of compression and the benefits to our patient populations, and that it is gold standard treatment for those with or at risk of delayed healing. And as Joe says, I think that the emphasis of delayed compression being a harm to patients is an important message that we need to relay to our teams, some of the perhaps more inexperienced clinicians who are dealing with wounds on the lower limb, to really highlight the power of the treatment and the importance of its early application. And this obviously should, of course, be supported with a holistic lower limb assessment and wound assessment, and also empowering patients to be partners in decision-making about their care and treatment. And this is supported by a wide range of compression therapy systems that are available on the market. It makes it easier to offer individualised treatment plans and promote patient choice. But I also appreciate that can make it quite confusing at times for us as clinicians about which one's the best to go for. So within my role, I see a range of wounds on the lower limb, predominantly as a result of trauma. But as most of you know, that is generally how a lot of leg ulcers might start. So having an early assessment of factors affecting wound healing, but also considering some of the additional factors as part of my role, is key to holistic assessment and to the application of early intervention and improving patient outcomes. So as well as the risk factors for delayed healing, we also have to think about the environment in which the injury was sustained, the location of the wound and the ability of the blood supply and other underlying structures that may be involved, the biopsychosocial components of wound healing, existing comorbidities, what the mechanism of injury was. Are there any iatrogenic causes? Have we got an internal or external fixation that are going to affect that calf pump? And also the knowledge and expertise of the clinic staff, because all of these do contribute to a significant and ongoing demand for lower limb wound care within orthopaedic and plastic surgery. So when I came into post in 2023, I undertook a retrospective audit of wound prevalence within the plastic surgery dressing clinic. And what this did was highlighted that patients with the lower limb wounds, in particular pre-tib lacerations, hematomas and skin cancers, were those with the highest number of clinic appointments per patient, which indicated that there were delays in wound healing, with some of these patients having up to 18 appointments for skin cancer wounds and 11 appointments for pre-tib lacerations. So we identified that there was a quality improvement opportunity here to improve holistic lower limb assessment, structured wound assessment and timely onward referral. And we developed an early intervention pathway, which saw a 50% reduction in clinic appointments for these patients. So you can see here, so there's an average of 8 appointments for pre-tib lacs, hematomas and skin cancers per patient. With early intervention, we were able to reduce that down to 5 appointments. However, with even earlier intervention, so very early referral for holistic lower limb assessment, we were able to reduce that down to an average of 4 appointments per patient. So that's the 50% reduction. And obviously with that, we also see significant efficiency savings as well. So our early intervention pathway, we developed a poster to display in the clinic rooms to highlight those patients that really should be referred to the complex clinic for early intervention. So of course, we've got the red flags for peripheral artery disease and infection. We've also got the pathway for patients where there's a normal healing trajectory that the nurses within the clinic are more than capable and competent to manage. But we've got those patients where the wounds aren't healing within 2 weeks, where there's a failed skin graft or full thickness graft, so there's less than 75% take on the lower limb, where there's any signs of venous disease within the lower limb, pre-tib lacs and hematomas, because we know they're going to have a protracted healing potential. Where there's inflammation and edema in the lower limb, any wounds that are left to heal by secondary intention, there's a reason that we've opted to heal those by secondary intention. So therefore, that is where the early intervention needs to come in. So once those risk factors have been identified, the patients would then get referred over to the complex clinic for early intervention. And this is where I will assess them, either myself or a colleague. We'll undertake that holistic lower limb assessment and will provide that early intervention and necessary care prior to diagnosis in line with the National Wound Care Strategy Programme for lower limb. And for the majority of these, it will be the application of compression in the absence of an ABPI. So the holistic assessment is pulse palpation and also listening to it with a Doppler, ruling out those red flags for peripheral artery disease that may, that will be, that we can't use compression on. But we'll use compression at a reduced level, refer out to the community services for district nurses to then do that ABPI within 2 weeks. We all know that there are pressures within the community services, and unfortunately not all of those patients have the ABPIs done within that time frame, and that is influencing the way that we're running these clinics so that we can do those ABPIs as well in time. But that's essentially how our early intervention pathway works. So these are some examples of patients who fall into that pathway. So this is a skin cancer. It was a lady who had an adequately treated high-risk squamous cell carcinoma excised from the lower limb, and her wound was left to heal by secondary intention. But the picture demonstrates what the wound was like after 4 weeks. So essentially this has now turned into a leg ulcer. So we undertook the holistic lower limb assessment and put her into a multi-component reduced compression system. And as you can see, 6 weeks later, the wound is almost healed and she's now in hosiery. And then we've got the hematoma. So this is an 80-year-old female with a left lower leg hematoma. We see numerous of these every week in the dressings clinic within plastic surgery. So this was a lady that fell and she tripped 2 days prior to this photograph being taken. Referred to the plastic surgery dressings clinic. X-ray didn't show that there was no underlying bony injury. History of osteoporosis, hypertension, and on aspirin for a previous TIA. So she was seen by the doctor within the clinic. They did an incision and drainage over the most fluctuant aspect of the hematoma here, debridement of the overlying skin, derafin of blisters, and then referred to my clinic where she was seen 2 days later. So actually it looks significantly improved 2 days later, but we can see those of you that are familiar with hematomas is that this is going to progress. It's going to be quite a nasty defect in the limb. So seen 2 days later, did the lower limb assessment, no ABPI, but listened to the pulses. We applied a polymeric dressing over the defect and a multi-component bandage system, and then reviewed her back in clinic a week later. But when I saw her a week later, she got worsening pain on the foot, heat, erythema, and generally feeling quite unwell. Now we know that iron deposition causes the release of free radicals into surrounding tissues, and that results in oxidative stress, increases the risk of infection in these patients. And unfortunately, this is what we saw with this lady. I was also quite concerned about the worsening pain over the foot and that this hadn't been x-rayed. So she went to ED for assessment. She had got signs of systemic infection, and so she was admitted for IV antibiotics. And unfortunately, she did show to have a deranged blood picture, which was investigated by haematology and diagnosed with a likely myeloproliferative neoplasm, possibly due to the iron deficiency. So she was discharged from hospital. A week later, she came into my clinic. The edema had significantly reduced. She'd been in hospital for a week with her leg elevated. The eschar had started developing, that was now demarcating, so we were able to do some effective debridement of that hematoma. Popped her back into the multi-component compression system, twice weekly care under the district nurse service. And as you can see here, 6 weeks later, the wound is significantly improved, and she's also maintained in compression hosiery. So then we've got pretibial lacerations. So we see a lot of pretibilacs in the plastic surgery clinic. Most commonly occur because of trauma to the lower limb over the tibia, and it's really susceptible to injury, particularly in the elderly, due to the physiology of their aging skin, polypharmacy, poor mobility, and other comorbidities that increase the risks of falls and injury. Due to these factors and also the really poor vascularity in this area, there is an increased chance of these patients developing a chronic wound. So we use the modified Duncan classification to classify lacerations. So a 1 is a linear laceration without skin loss. 2, flap laceration with a viable flap, where we may be able to reapproximate that flap. 3, a flap laceration with a non-viable flap, which is going to need debridement. 4 is skin loss, and 5 is laceration with hematoma, that will need an evacuation of that hematoma. And it is only really 5 that may require surgery, but particularly within my trust, the consultants generally tend to opt for conservative management with dressings for all of these patients, and therefore it is so important to have that early intervention, even for the classification of 1, especially in the presence of those risk factors for delayed healing. So this lady is one of our conservative managements. She was a modified Duncan 3, so she got a flap laceration with a non-viable flap that required debridement. She was put into a multi-component compression bandage system, and we saw within, again, about 6 weeks, we've got that reduced edema and we've got wound healing. But unfortunately, for pretibial lacerations and hematomas, there is really a lack of standardised approach to management, and it does vary between clinicians, between trusts. Even those that are in close proximity to each other. So there is ongoing work in the background to see about how we can standardise these approaches. But what that means is that there is delayed wound healing and increased burden on resources. It's a predominantly elderly population where a conservative approach is favoured. And that's why it's really important that we have that early compression, because it's key to reducing complications and improving the outcomes. So how does this transfer across to complex lower limb surgery within orthopaedic surgery? So management of open fractures is probably 50% of my role in combination with plastic surgery. So open fractures are defined as fractures which communicate with the outside environment through a soft tissue wound, most commonly occur on the lower extremity and the tibia, or they can occur anywhere in the body. They are a challenge to manage, and historically they would have resulted in amputation, sepsis, or even death. And it is the open element of the fracture that increases its complexity, and it predisposes the fracture site to detrimental complications. So our patients that come across from Anglesey or in the Peaks, they've often fell within dirty environments. They may have fell in water. So it's the contamination and that, the whole holistic assessment of the patient that really determines the level of debridement and interventions that are going to be needed for these patients with these open fractures. But also the internal degloving of soft tissues can be really problematic with delayed presentation of injury severity. So open fractures are classified using the Gustillo-Anderson classification. So type 1 is limited periosteal stripping, clean wound, which is less than 1 centimetre. You can see that picture just here. You've got type 2, which is mild to moderate periosteal stripping and a wound that is greater than 1 centimetre in length. And your types 3, A, B, and C. So these are your more significant soft tissue injuries and vascular injuries where significant soft tissue reconstruction as well as orthopedic reconstruction is going to be needed. However, those type 1 injuries, you can see here is that is a small, less than 1 centimetre puncture within the skin, but that significant area of degloving and surrounding tissue could mean that there is a significant defect within that skin. And you can't heal, you can't definitively close a fracture or manage a fracture without healing the skin over the surface and having that definitive soft tissue closure. So we use a reconstructive ladder within plastic surgery, anything from simple to complex. So your simple is your healing by secondary intention and primary intention. We might need to use skin grafts or bioengineered tissue. Tissue expansion, not really used within trauma, but it is one of the tools which is in the box of plastic surgery. But most commonly, we would use skin grafts. We would use a regional flap or a free flap to heal over the defects. Of course, the primary goal would be to be able to close a wound with an incision, and we would generally use a negative pressure system for incision management over the top of that just to promote that healing. So orthopedic fixation then, quite often we will need to do a temporary external fixation within the first 24 hours of the patient presenting to us. And it will be a temporary fixation to allow us, if we've done a primary closure of the wound, to allow us to assess those soft tissues before proceeding with the definitive orthopedic fixation. And that might range from the use of a frame, so a long-term external fixation. This is really helpful in treating complex fractures, those with malunion, or where there's been a significant area of bone debrided or lost as a result of the injury. And it's also used for limb sparing surgeries where just other options are just not feasible. So, if we've got the tibia that's broken into multiple pieces. The definitive fixation of choice and what we see more frequently would be the intramedullary nailing, and it's a strong and stable fixation for the fracture that helps with bone healing. And the intramedullary nailing really helps us to get the patients mobilizing as quickly as possible, because even with the bone that isn't healed, the movement of the walking causes small hematomas around the fracture site. But what that does, that releases growth factors and a bone healing cocktail really to speed up that process of healing. But as we see with a lot of the elderly and a lot of the very distal tibial fractures and pilon fractures, the increased use of hindfoot nailing So as you can see, this is a rod that goes through the calcaneum and then and a nail that's inserted there. There's a rise in prevalence of fragility ankle fractures within the elderly population, and they are associated with significant morbidity and mortality, quite commonly seen in osteoporotic females. And most of the evidence is around the use of fragility ankle fractures in the elderly, but we have to be very selective around who we use this technique of fixation for, because it does fix the ankle in a position so you don't have that flexion and extension. So in a very active patient, this wouldn't be the fixation of choice. But because of that fixed ankle position with instrumentation, combined with vascular injury and trauma to the soft tissues, it does present real long-term challenges with secondary edema and wound healing. So looking at some case studies of open fractures then. So this was a 44-year-old gentleman who was a polytrauma motorcycle versus a lorry. As you can see, multiple injuries, including an open fracture of his femur and an open fracture of his tibia. So he had an IM nailing of his femur and the application of an external fixation to the tibial shaft and the first operation that he underwent. And then a week later, he went back to theatre to have the IM nailing of the tibia and a split skin graft to the defect over his calf. So that was in December of 2023. So maintain contact with the patient, and then the photograph that the photograph that I received here was 6 o'clock on a Thursday night, and it's not what you want to see. And obviously I had to act on it at that point. So significant swelling, pain behind the knee, felt that his calf was really tender to touch. So we got him in to our medical unit to exclude a DVT, which we did. His CRP had remained in the 60s. He got edema and he got pain, but we were able to exclude that DVT. So I brought him back in the following day and applied a multi-component compression system. And as you can see from the photograph here, there's 4 days in between this photograph here and this one. And with that, he got improved pain. The edema had reduced, so his ankle circumference had reduced from 25.5 to 22.5 centimetres. He'd got really good guttering of the skin, so you can see that he'd got really effective compression of that lower limb. And also we'd moved to wound healing within a real, short amount of time. He has remained in a compression hosiery just to support that ongoing venous return, because we know that there's been a significant injury to the vessels. This was another open fracture, 25-year-old male, motorcycle versus a post. So he had an open tibial fracture in May of last year. So his initial surgery, he had washout debridement and primary closure and the application of a temporary external fixator, which you can see here. But as you can see, where they had this primary closure, he went on to develop some necrosis. And that really just emphasises why we have that approach of temporary fixation externally when we've closed those fractures. Not all of the time, some of them, where there's a really neat approximation under very, very low tension, we may opt to do the definitive fixation at that point as well. But this was quite a complex one. So he had to go back to theatre and he had to have that area of tissue debrided, and the application of his definitive fixation, which was a circular frame. So his soft tissue defect was using a radial forearm flap, so a big area of tissue that's taken from the volar aspect of the arm, using the radial artery, and then that is a free flap that is then transported to the distal limb, as you can see here. But this patient presented with pain, edema, congestion, and a pain score of 6. So we did the application of an inelastic base layer of compression, so 20 millimeters of mercury, just using the base layer, which it was a real challenge to do. You can't really see from this picture, but there was lots of very fine wires and pins around this circular frame. So it was quite a challenge to get the compression applied here. But what we saw with this is that his pain score reduced to 3, his edema reduced, his congestion reduced. So we maintained him in compression with his circular frame until the point that he went into Sarmiento cast, which is a cast just above the knee, which also did provide a little bit of light compression. This was another chappie. So this was a farmer who was a fall from a quad bike, open tibia, peel-on fracture. So you can see it's the distal limb that was affected here. Quite a nasty fracture, and also a fibular fracture as well. Now, unfortunately, so this happened before I came into post, but he did fall through the gaps, and he was lost to follow-up until January of 2024, when he was referred because of a non-healing donor site. And this is how he presented to me. So he got venous stasis, eczema, he got quite significant edema. Again, this was a radial forearm flap like we've just seen in the previous image. So we commenced with just a mild topical steroid to treat the stasis eczema, and he was a Welsh patient, so referred him over to the district nurses, who were able to put him into a compression wrap, and within 7 days, that was the difference that we saw within that flap. He does have ongoing episodes of venous stasis eczema within this flap, but he's also had to have multiple other operations because of failure of metalwork and non-union. But he has maintained in compression. He's now in hosiery, and doing absolutely fantastic. This was a workplace injury sustained in November 2024. So a really nasty degloving injury with multiple fractures of the distal limb, also a vascular injury and tendon injuries. Initially, he came, had an ankle wound debridement, application of an external fixator. So that was a temporary measure, the use of negative pressure, just to kind of monitor the soft tissues, because he then had to go back for a second debridement. Quite a large defect here. So this was an anterior lateral thigh flap that was used. So that's skin and muscle that's taken from the thigh along with its arterial supply, and then that's transported and fixed in place over the defect. So initially, what happens with these flaps is that they can have quite significant edema within them as well. And there was a small non-healing area just on the suture line, nothing significant, but we knew that by putting him into some compression that we were going to just help to speed that process up to wound healing. So initially in a multi-component bandage system, and then we switched that to a compression wrap so that the patient could manage it himself. And we saw here that there was a reduction in edema by 3 centimetres from his ankle measurement. And this is what we commonly see with these real distal areas, is that where the flaps go over the malleolus and into the foot, is that this can present real challenges with footwear for some patients. But actually, with the use of the wrap and the sock, which has got an element of compression in there as well, is that actually he was able to go back into his normal footwear, which is really important for patients because he wanted to get back to work as well. But such a significant improvement in the healing of the suture line as well, just within the space of 14 days. So then there's the complex orthopedic surgery as well. So this was an 88-year-old gentleman who previously had a left ankle fusion. He had infected metalwork, and this was removed in February of this year. He also had Cerament G, so this is gentamicin into the screw sides to prevent the onset of osteomyelitis. He was closed primarily, so this was a closed incision, which then obviously, as you can see, has deteriorated quite significantly within 4 weeks. It got edema, it got inflammation, it got stasis eczema, it's got wound dehiscence, and he's also got the moisture-related skin changes because of the significant output. With the Cerament G is that we do see a higher volume of exudate with this, and that's kind of normal with the use of this product. But obviously this isn't great for patients' skin. Prior to the removal of his infected metalwork, he was seen by a vascular surgeon, and he did have an ABPI. So quite significant peripheral artery disease in the right leg. However, it completely asymptomatic, but a much better, I say much better, a better blood supply within the left leg, which meant that we were able to put him into, again, the multi-component compression kit. We expected this to be a slow progress because of all of the underlying features, age, etc. But actually, this photograph was taken last week, and we can see that the wound is healing. And I'm confident that we're going to get this to heal over the next few weeks. He's just got some small areas of overgranulation within the wound bed here, but within here there are like channels of epithelialization as well. So everybody is really, really happy with this. So in summary, we know that compression therapy significantly reduces edema, promotes wound healing and improvement of other related symptoms such as pain, stasis eczema, in patients following lower limb trauma and surgery. It's not just for venous leg ulcers, but it serves as a preventative treatment for those with complex lower limb injuries, because we know that that healing trajectory is going to be prolonged, and for many of these, it will turn into a leg ulcer. It should therefore be considered for all lower limb wounds where risk factors for delayed healing are identified. It should also be considered, where possible, preoperatively for patients where risk factors for delayed healing are identified. And for us in particular, that's those patients with who are coming in for excisions of cancers on the lower limb. And we also know that there's a range of compression therapy systems available that help to meet the needs of complex patients with lower limb injuries. Thank you.
Thanks, Steph. That was really interesting. And yeah, I apologize for those that were struggling to see the slides. It was out of Steph's control. It was the problem. We usually, we often will get these techie problems, but you presented it brilliantly. So thank you, Steph. We've just got a couple of minutes for questions. Lots of comments about how interesting it was in the chat. You can go in and have a look, Steph. I'm just sort of kicking off really, Steph, because this is about challenging historic practice, and what you're doing there in your hospital, your trust, is incredible, and you've got data to demonstrate the results. Was it difficult to get the whole multidisciplinary team on board, or was everyone very supportive with this sort of new approach using compression?
Yeah, everyone really supportive, and my role was kind of created on the back of some of these challenges that we have within plastic surgery. Lower limb wounds and scalp wounds are our particular biggest challenge. So actually, I think they didn't previously have the expertise to be able to come in to these specialist areas. Obviously, we have got an amazing tissue viability team, but I'm working predominantly within these outpatient areas as well. So quite often these would have to be pre-planned appointments. So again, it's bringing patients back in. It's then, looking at the workforce within the tissue viability team, they're not able to follow these patients up. So actually, all of the plastic surgeons, all of the orthopedic surgeons are fully on board. But what's happening now as a result of that is that those that don't fall within orthoplastic trauma and just fall within orthopedics, they very much, the foot and ankle surgeons are actually buying into this more and more now, and they want this to be part of their standard pathway. So I need to build a team around me for us to be able to facilitate this.
It's also spreading the word, isn't it? And hopefully, it's not just like isolated trusts. It should be the go-to, as best practice across all of the plastics teams across the UK. I've just quickly having a look at the chat. Steph wants you to explain the term guttering of the skin in relation to the compression.
Yeah, so I don't know if you could see like the marks on the skin where the bandage had been applied, and what that does, it's termed guttering. And what it does, it just demonstrates that we've got that real effective reduction in edema, and supporting that blood flow back up to the heart.
Absolutely. If you're seeing it, you're doing a good job with your compression. There's a question, just a final question here from Coral, about what do you mean by congestion in an open fracture?
So within an open fracture, and when we're using a flap, so the venous pooling into the flap is what we term congestion. So what you might see within that then is that you see like a bluish tinge within the lower limb, but also congestion within a flap can be really detrimental. It means that that may mean that the patient has to go back to theatre because that is a buildup of blood that just isn't getting out of that flap, which can cause pressure on the whole of the system.